a 5-minute announcement or 5-10 minute announcement, and whenever they're done, Tom will get started on his lecture on pharmacology, and the lecture recording should be up by Tuesday on the MUMUS YouTube channel. All right.
Thank you. I'm not sure, am I able to share video?
Yeah.
Yep, easy. Cool. Alrighty. Hi, everyone. My name's Kale. I'm the State Business Development Manager at MDA National. I'm probably already on the back foot presenting to you on a Sunday morning, on a long weekend, and the morning after a grand final. But I will keep this brief. I know you've got better things to focus on. Usually we would have met a few times on campus over the year, but unfortunately this sneaky pandemic keeps keeping us apart. Most of you are probably already members of MDA National, but if you haven't signed up, you still can. We've got a few copies of the free Oxford Medical Dictionary, which we will send to you to help you through your studies. I guess you're probably thinking, I'm only a first-year medical student, why do I need my own indemnity insurance? Well, you do have some cover through the hospital, but they don't cover you in all circumstances. So having access to your own medical legal advisor protects your interests and provides you with independent advice outside of university. Some examples of where we've assisted medical students in the past include allegations of academic misconduct or a breach of examination rules, assistance with bullying or harassment, helping a medical student write and review a police statement when they're on clinical placement, career advice and guidance, and also improper capture or use of clinical images is another one. The other thing is we automatically cover you for your electives anywhere in the world, excluding the USA, if you do choose to do an overseas elective as well. Basically, if you're in doubt, call us. And that's something that Dr. Sarah Bird, who is the manager of our medical legal team, is really passionate about. No query is too silly or too small. The other thing you're probably thinking is there are 4 medical defense organizations. Why do I need to sign up to more than one? And don't you all do the same thing? Well, you're right, we do offer similar coverage. However, I guess the point of difference really comes down to service. So whilst you're a medical student or even a junior doctor and your indemnity insurance is free, put us all to the test. I know it sounds silly and time consuming, but if a situation does arise where you need us or you need advice, call all the insurers that you're a member of. Find out which one answers the phone when you call for medical legal advice at 3 a.m. or on a weekend. Find out who provides you the most comprehensive and easy to understand advice. And most importantly, which organization made you feel supported. It's better to find out early on in your medical career rather than waiting until you're a junior doctor when you're only stuck with one insurer, for example, only to find out when you call up, they don't meet your expectations when you needed it most. And the other thing is before you start your clinical years, MDA National always offer a wealth of educational webinars and resources to help with things that may not be covered as part of your curriculum at university, such as communication or ethical situations. Some of the topics we've covered on our website library include respect and responsibilities during intimate examinations, career complications and contending with uncertainty, tips for approaching difficult conversations with a senior colleague, and handling the challenging emotions of difficult news. To be honest, the majority of medical students and even junior doctors don't take advantage of the services offered by their medical defense organizations. Sometimes it's because they genuinely don't need to, but also it's often because they don't know what's available. So when you are faced with problems, and especially if it's a threat to your career or your professional standing, that's when you want the highest quality of service that you can get. And that's when you find out, I guess, the true value of being part of a medical defense organization that really cares about you. So just to make sure you're all still listening, I think I can pull up my contact details on the screen. Give me 1 second. So all my contact details are up there. So if you're not a member, sign up and we'll post out the dictionary to you. And also for the first 20 people that email me, 20 members, I'm going to also send out a copy of Dr. Sonia Henry's novel, Going Under. I'm not sure if you guys have heard of this one, but I've read it myself and there's definitely quite a few laugh out loud moments in there. So sign up. If you've got any questions, or you've got my contact details there as well. The final thing is that I guess I know it's been a challenging year for you guys, but you're on the home stretch. Best of luck for your exams next month. Keep the coffee levels up, and also don't forget about balance. Most important, keep up your exercise and plan time with your family and your friends. I'm going to also leave my contact details for you guys in the chat. Hopefully this gets to everyone. There you go. Alrighty, thanks guys.
All right. Thank you so much.
No worries.
Whenever you'd like, Tom, you can get started. And yeah, cool.
Awesome. Alrighty. Let me just share my screen. Could someone just quickly post a message in the chat just to make sure that everyone can see the PowerPoint?
It's all good.
That's good. Cool. All right. Well, my name's Tom. Today we're going to be covering a bunch of pharmacology, everyone's favorite subject. I know a lot of people find pharmacology pretty tough in SEM 1 and SEM 2 alike, but hopefully we're going to try and break that down to make it a little bit easier. So today we're going to be covering all of this stuff. So pharmacokinetics, autonomic nervous system, pharmacology, DMARDs, analgesics. I'm not sure if you guys have covered cardiac drugs, but I've put in the slides anyway. Even if you don't know what's going on today, the video will be up on YouTube, so you can go back and check on it. Oh, well. So here is a mark breakdown from 2018, I think. So you can see that pharmacology does make up a pretty substantial part of the exam. In this, it's about 12–13% of the marks. So it's not going to be as much as anatomy or physiology or something like that. But it is important to have a pretty solid understanding of. The problem with it is that with pharmacology, you can just keep on going into more detail. The list of drugs never ends. So I think it's about striking a good balance, basically by focusing on the things that are going to be most high yield. So, okay. Here, a bunch of resources that I think are really useful. So number one, for Anki, I say this is the best thing you can do for yourself when it comes to pharmacology. Pharmacology is a lot of rote learning. And so if you have a system where you're forcing yourself to really actively learn these things through spaced repetition, this is really going to help you out. And frankly, last year when I was studying for pharmacology, Anki is what helped me the most. You can check out the MUMUS academic drive. I would recommend, if I've got a few practice questions in this, but if you want some more practice questions, I'd recommend going back and looking at the revision lectures from the previous years. Big shout out to them, because this is largely inspired by them as well. But there's more questions and everything there for practice. You can go on YouTube, you could do a quick search for pharmacology and you'll be able to find lots of stuff. E-pharmacology is really useful. It will tell you what the core drugs are and really what you need to know for the exam. And then I don't know if I really recommend this, but if you really want to get into the nitty-gritty of it, you can look at Rang and Dale's pharmacology, but like it's not really necessary. You don't really need to know it in that much detail, but if you want to learn all the physiology behind it and really get a pretty in-depth understanding, that's a good way to go. So yeah, Sem 1, rote learning, not great. Sem 2, it's largely based on physiology that you've already learned. That doesn't really make it easier, but it does mean that you can start to make some more connections about why things are happening rather than just simply knowing it. So that's an advantage of Sem 2, and I'd say try and harness that to your best advantage. So when you're tackling a drug, you want to first target A, what's its mechanism of action? How does it work? B, when is it used? What are its indications? C, contraindications. When don't we use it? What are the side effects of the drug? And also, some drugs will have some extra information, which we'll see throughout the presentation. So we'll get the ball rolling with pharmacokinetics. So the mnemonic for pharmacokinetics is going to be ADME. And A in ADME is for absorption. So there's a couple of terms that we need to know here. The first of all is bioavailability. So this is how much of the administered dose reaches the bloodstream unchanged. So if you put something straight into the bloodstream, that's going to be 100%. But if you administer something orally, that's going to go through the most changes. So it'll have the lowest bioavailability. Bioequivalence is 2 formulations of drugs with similar concentrations. It's basically when looking at generic, like Audi brand drugs or something like that. Oral administration, the absorption is going to be dependent on things like gastric contents, gastric motility, gastrointestinal blood flow, acidity, whether it's lipophilic or lipophobic, and they'll determine whether it gets absorbed in the stomach. But the small intestine is generally the primary site, and you also have to count in the first pass effect, which is the amount of the drug inactivated by passing through the liver before it goes to the systemic circulation. Parenteral administration is more predictable, but it can hurt. And then, yeah, inhalation is going to get to the body the quickest, orally will be the slowest. Distribution. Okay, so this is something that is, in my opinion, not taught very well by the faculty. I went to the lectures and just didn't understand what was going on. I think the most important thing to understand when it comes to volume of distribution is just understanding that it is the amount of the drug administered divided by the plasma concentration. So if we're talking about a drug with, so we'll say that every drug, it has an equivalent dosage, right? We've given 1 gram of everything. If we have one drug that you then see, I don't know, 0.05 grams in the blood, that's going to mean all the rest is gone out to the tissues. And therefore, if we compare this with a drug where 0.5 grams is in the blood, it's going to mean that you're going to need more blood for the first one to have the same amount, if that makes sense. So 0.05, you're going to need 10 times more than the one with 0.5. And therefore, the volume of distribution is going to be 10 times higher. I'm not sure if that makes sense. Please send me a message if that doesn't make sense. But basically, the lower the concentration in the plasma, the higher the volume of distribution, and therefore more of the drug in the tissues. Okay, so if it's bound to a plasma protein, that's going to bring more of it into the plasma. And that's going to, no, that's, okay, now I'm confusing myself. That's going to mean that more of more of it is bound, more of it is in the plasma. I'm going to have to come back to this. I'm confusing myself, but remind me to come back. All right, so for this one, right? Yeah, now, okay, I don't know what was going on with the slides. If you've got plasma protein binding, it's going to have more of it in the plasma. And that's going to mean that the volume of distribution, so the amount of volume that you're going to need to have all of the dose in it, is going to be lower. Whereas if it's binding to stuff in the tissues, that's going to mean you're going to need more plasma to make up for it, because it's going to have a lower plasma concentration. Please send me a message if that doesn't make sense, because it's a pretty tricky concept. All right, so we have a concept called the steady state. And basically the bit that I've put in bold, it takes 4 to 5 half-lives to achieve a steady state. That is the most important thing you'll have to know about this. You can give this graph a look, but a lot of the time there's got to be questions on exams where they're asking how many half-lives it takes to achieve a steady state. Yeah. So M&E, metabolism and excretion. So clearance is just the capacity for the body to remove a drug, either through liver metabolism or renal excretion. Therapeutic index is the result you get by dividing the toxic dose of a drug by the dose for therapeutic response. So if 200 milligrams is toxic and the therapeutic dose is 20, that means your therapeutic index is going to be 10, so 200 over 20. And basically, the higher the therapeutic index, I guess the safer it is. It's less likely that you're going to get toxic effects. If they're really close to each other, it starts to get a little bit dangerous. Metabolism. So you have liver enzymes that will basically prepare insoluble molecules for excretion. So there's 2 phases. The first one is about polarization. So this is often removing a functional group, and this makes it more water soluble as it's an ion. But it can also be toxic, so you're going to have to put it through another phase. And some key enzymes that are used for this are CYP450, alcohol dehydrogenase. The second phase is anabolic, and so this involves conjugation. So you're adding stuff to it to increase its size, polarize it, and this makes it inactive. And then we have excretion, which can be through all sorts of this stuff. And filtration plus secretion minus reabsorption is the clearance rate. That's something you're going to see a lot in second year. That's to do with lots of renal excretion and stuff, but it's nice to have a general idea of that. First order kinetics. So basically in first order kinetics, it means that the higher the concentration of a drug in the body, the higher your elimination rate is going to be, just because it increases the likelihood of the substrate binding with the enzymes in the body. But that's only assuming that there are still enzymes available to react. If there are no enzymes left, then it becomes 0 order, where it's just a flat linear gradient, because well, if all the enzymes are taken up, you're not going to be able to increase the rate by increasing the amount of the substrate in the body. And so the classic example of this is alcohol, where all your enzymes are taken up. So alcohol is eliminated from the body at 1 standard drink per hour. And that's a flat rate. I'm not going to touch on this too much. I would definitely recommend just sitting down and looking at this. Just remember that if we go down this side of the triangle, this is got to be renal excretion is equal to clearance times by plasma concentration of the drug in the body. And then this rule works for all of it. Again, I'd sit down and look at this in your own time. So a bunch of questions. If you just want to chuck your answer in the chat. Which of the following would indicate high plasma protein binding? So high volume of distribution, high tissue sequestration. Yeah. Can you please clarify? Yep, so the answer should be C. Yep. May you please clarify? Okay. So do you want me to go over the, yeah, I'll quickly go back. So I think that these might be the wrong way around. Looking at this, let's focus on this instead. So we're just going to quickly go over volume of distribution again. If the concentration of a drug in the plasma is higher, that means you're going to have less of that drug in the tissues. And so that's going to mean that you're not going to need as high a volume to get rid of it. So assuming, it's a pretty tricky concept. I can understand why the faculty struggles a bit with teaching it. Assuming that the rest of the tissue in the body is like additional plasma beyond what we actually have in our body, how much volume would we actually need to get rid of all the drug, or to contain all the drug, rather? So if you've got more in the plasma, this is going to mean that you're going to need less volume filtered, or less volume needed to hold all of it, because there's less in the tissue. And if there's less in the tissue, that means that there's a larger amount already in the plasma. And that's going to mean that you're going to have a lower volume of distribution. Does that kind of make sense? Kind of like equilibrium in chemistry. Let me think about that. I should know this. I teach chemistry. No, I don't think so. I wouldn't think about it that way. If anyone, after this, if anyone still has any questions, and keep asking questions during this, I think it's great. But if anyone still has questions, please feel free to just chuck me a message on Facebook. You've got my name at the start of the slides. Does that mean it is excreted quick? I have lower volume. Yeah. All right, cool. So which of the following are true regarding the therapeutic index? The ratio of therapeutic dose divided by toxic dose. The higher the TI, the more dangerous. Therapeutic index is an indication of the safety margins of a drug, or lipophilic drugs generally have a higher therapeutic index. Yep, so it's safe. Let me just get my timer. Cool. Just making sure we're running on time. Yep, so yeah, it's just to check how safe the drug's going to be. Which of the following most directly influences the rate of elimination of drug X? Clearance, water solubility, bioavailability, first pass metabolism, or volume of distribution? Not quite. I think this is going back to the pharmacokinetic triangle. Yeah, it's going to be clearance. Again, I think I'm going to have to chat with the people putting up the slides. I'm going to do a double take on that, and I'll try and get an announcement up, just so that we can make sure that all the stuff about volume of distribution is correct, because I don't want to be confusing anyone. All right, so now we'll move on to the autonomic nervous system. So we have the parasympathetic nervous system and the sympathetic nervous system. Sympathetic is going to be a fight and flight response. Parasympathetic is going to be doing all these effects like constricting the pupils, stimulating salivation, slowing the heartbeat, basically just relaxing stuff. And you guys have probably covered this a fair bit, but I'll quickly go over it. In sympathetic, at the ganglion, you're going to have a nicotinic receptor where there's going to be acetylcholine going over, and then norepinephrine working at adrenoreceptors. Parasympathetic at the ganglion, also nicotinic with acetylcholine. And then at the effector organ, you're going to have a muscarinic receptor, which uses acetylcholine. These ones probably aren't as important, but nice to know anyway. At the adrenal gland, you're going to have a nicotinic receptor that then leads to epinephrine or adrenaline, noradrenaline being released. And then for somatic, you're not going to have this ganglion. It's just going to be a nicotinic receptor at the skeletal muscle. So this is a really fun thing to memorize. You're going to have all sorts of different parasympathetic receptors. I'm not really sure how much detail you need to know this in, but I would make some Anki cards about it or something just to make sure that you're familiar with it. M1, gastric stuff, salivary glands. M2, atria of the heart. M3, smooth muscle, vascular endothelial. M4 and M5, not really known, but it's in the central nervous system somehow. And these are all just going to do relaxing things. I'd look through this again just to make sure that you know it. But if you just think about things that are going to be relaxing the body and that you're not going to want to be doing, if there's a lion chasing after you, then I think you'll be all right. A nice way of remembering this is just going down the body and back up. So head, heart, abdomen, back to head. Cool. Then we have our sympathetic receptors. So we're going to have alpha-1, which is for vascular smooth muscle, the eye, urinary smooth muscle. Alpha-2, you don't really see it a lot, but it's for presynaptic nerve terminals. Big 2, I suppose alpha-1 is pretty important, but the big 2 are really beta-1, which acts on the heart, the kidney, and the eye, and we're going to see this a bit later. And beta-2, which is for the bronchiole, it's for vascular stuff. And I think it's important to understand here as well that it's not going to constrict the bronchioles. It's going to relax the bronchioles in this case, even though it is a sympathetic response. And that's because if you're running away from something, you're going to want to get more oxygen in. Whereas with the heart, you're going to want to pump that faster. Yeah, just a small thing, alpha receptors, noradrenaline is the strongest isoproterenol. I don't even know how to pronounce that. Isoproterenol? Yeah, for beta receptors. You can look through it if you want, not too important. All right, so some adrenergic drugs. We have our beta agonists like ethimoterol and salbutamol. These are both drugs used for asthma. And so these will mediate the sympathetic nervous system. Beta-1 acts on the heart. It's going to lead to cardiac contraction. Beta-2 acts on the lungs, leads to bronchodilation. Beta blockers are going to have the opposite effect. So if you've got high blood pressure, this is going to lower the heart rate and also mean that the heart isn't beating as strongly. However, even if it is a beta-1 drug, it's still going to have some beta-2 effect. And so we don't want to give these to asthmatics because that's just going to constrict their bronchioles even more. And as someone with asthma, I can tell you that no one wants that. Cool. So we have our anticholinesterase inhibitors, for example, pyridostigmine. So anticholinesterases are enzymes that break down acetylcholine. So if we have less acetylcholine being broken down, it's going to stay in the synapse. And the parasympathetic activity is going to be increasing. This can exacerbate some conditions. It can lead to, it can be used for myasthenia gravis. We also have muscarinic antagonists like atropine. This is a competitive muscarinic antagonist. This has some sympathetic activity as you're going to be preventing acetylcholine from binding. So this can lead to mydriasis, which is dilation of the pupils. And it's often used for things like eye exam or organophosphate poisoning. We have muscarinic agonists. So yeah, that'll be the opposite, used to constrict the pupil, increase gastrointestinal motility, lead to bladder emptying. And we have botulinum toxin, which will stop the release of acetylcholine, which will have pretty widespread effects since acetylcholine is everywhere. Somatic and parasympathetic and ganglionic nerve receptors are disrupted. If you ever see someone with botulism, their body just becomes kind of wobbly. They can't really do much, and it's pretty distressing. So you really want to be pretty careful with this one. It's only really used in severe pain. And this is a nice little diagram to kind of break that down a little bit. You can see botulinum working here, so acetylcholine's not going to be able to exit cytose. And anticholinesterases working here in the synapse aren't going to be able to break down, or are going to inhibit the action of this from breaking down acetylcholine. Yep. So just look back through that. And then here's a nice little mnemonic for learning the parasympathetic effects. Dumbbells, you can look through this in your own time. But a lot of the time, I think if you just work through every system and think about what you'd want when you're relaxing, it probably makes sense. Again, let me know if anything's unclear in this, and I would be more than happy to help. So, first question. A patient presents with fever, flushing, and constipation. These are all signs of an overactive what? Yep. Sympathetic nervous system. Yeah, cool. Which of the following would you advise giving again? Well, would you advise against giving to this patient? What causes the fever? It's just going to be to do with, I assume it's to do with just the heart beating faster. Beating faster, beating harder, you're going to have more blood rushing around. Yeah, not sure on that, but that's what I would have thought. The giveaway for me is really honestly, it's the constipation. Which is, yep, so it's going to be both formoterol and atropine, because these are both going to exacerbate sympathetic activity. Which of the following drugs would be contraindicated in asthmatics? Yep, C. So that's a beta blocker. Don't want to give that to asthmatics. They won't be very happy. And what is the mechanism of action of pyridostigmine? Yep. So it inhibits anticholinesterase, increases neurotransmission. Awesome. So going on to DMARDs. So we have our 5 arms of inflammation, which are dolor, pallor, rubor, tumor, and functio laser. When I was learning this, I suddenly really wished I took up Latin or Spanish in high school, but alas. Anyway, you'll have to go through these and remember that. So we know that rheumatoid arthritis is caused by an overactive immune system in your joints. So the drugs that we're going to be using are going to be to do with shutting that down. Methotrexate, it inhibits the enzyme dihydrofolate reductase, decreases DNA synthesis, inhibits T and B cell function. This is a cancer drug, but we use it at very low dose. So we have to be pretty careful with this, because it can lead to the things you'd expect with chemotherapy. So myelosuppression, bone marrow suppression, it's bad for the liver, all that. Leflunomide, also immunosuppressive. It suppresses T cell proliferation by inhibiting dihydroorotate dehydrogenase. It's used in rheumatoid arthritis and psoriatic arthritis. Diarrhea, hepatotoxicity, teratogenicity. A lot of these things you're probably not going to be tested on, like these little nitty-gritty things. You're going to be wanting to look out for buzzwords and stuff. But even then, I would recommend putting these into flashcards. In the end, like if you understand what these drugs are doing, it's going to help you a lot when you get onto clinical and when you're future practicing doctors. Azathioprine. So this is a purine analog, inserts itself into the nucleic acid of the lymphocytes and stops purine synthesis. And this will stop T cell proliferation. And this can lead to some allergic reactions, and it's bad for the liver. Cyclosporin, calcineurin inhibitor, binds to cyclophilin and prevents T cell activation. And leads to, it's bad for the kidney, leads to hypertension, hyperlipidemia, neurotoxicity, again, used for rheumatoid arthritis and psoriasis. Infliximab, so this is a monoclonal antibody, so this is just an antibody that we produce. Oh, sorry. Does methotrexate block folate acid? Yeah. So dihydrofolate reductase is involved in the production of folate. So infliximab and rituximab are both monoclonal antibodies. Infliximab is going to be targeting TNF alpha, which is a cytokine that mediates the Th1 immune response. Again, this is something you're going to cover a lot in second year, but probably just good to know some of these buzzwords for now. Leads to immunosuppression, reactivation of infections, largely because of that. And then rituximab is a CD20 inhibitor using cancer, rheumatoid arthritis. These ones, you don't see too much, especially the second one, anakinra. I genuinely didn't know this was a thing until I made these slides. But you know what? Maybe you guys will just be better first years than me. Sulfasalazine lowers cytokines. Anakinra, IL-1 receptor antagonist, inhibits inflammation. This is done through subcutaneous injection. And everyone's favorite, hydroxychloroquine. It's actually a pretty versatile drug. So, but yeah, just trust me. It blocks toll-like receptors on certain dendritic cells, and it's not used for COVID. Cool. So, management of gout. What we're going to want to do here is we're going to want to reduce the amount of uric acid produced, decrease the amount of uric acid in the body, and decrease the amount of immune cells going to these sites where you're getting this uric acid buildup in gout. So to start off with, we have allopurinol. This is used for chronic gout, and it's a competitive xanthine oxidase inhibitor, which is the enzyme that converts xanthine to urate. Yep, leads to GIT disturbances and stuff. Colchicine, this is for acute cases of gout. And so this inhibits microtubule depolymerization, and this will then impair chemotaxis or movement of neutrophils to the site. And you also have some gastrointestinal symptoms. And probenecid, which inhibits uric acid reabsorption in the kidneys. Yeah, cool. And here's a little diagram to make sense of this. I'm sorry if it seems like I'm going through this a little quick. There's just a lot to go through, and 1 hour really isn't enough time to go through pharmacology in depth. So, but again, feel free to send out a message if you need some help. All right, so which of the following is not a sign of inflammation? Yep. The pallor. If someone is presenting with pallor, that actually means paleness. Definitely won't expect that in inflammation. Which of the following best describes the mechanism of action of methotrexate? Yep, awesome. So I guess now you can make that connection between methotrexate and folate. And luckily, enzyme here has folate in the name. The first one, azathioprine purine analog, that's kind of the buzzword. You can remember this enzyme. So dihydroorotate dehydrogenase, that's leflunomide, and monoclonal antibody targeting soluble TNF alpha is going to be infliximab. Just remember that any monoclonal antibody, so methotrexate isn't a monoclonal antibody because any monoclonal antibody is going to have mab at the end of its name, like infliximab, rituximab, that kind of thing. Cool. Which of the following best describes the mechanism of action of allopurinol? T cell activation by preventing IL-2 transcription. Yep, C, lots of people. Awesome. So the first one, IL-2 transcription, that's got to be cyclosporin, not even for gout. Inhibit microtubule depolymerization, colchicine. Inhibit renal absorption of uric acid, that's got to be probenecid. Yeah. Which of the following is used in an acute gout attack? Yep, so that's gotta be colchicine. Allopurinol is used for chronic. These two didn't really say. The two that you have to remember are colchicine for acute, allopurinol for chronic. Cool. Going on to pain management. So this is just kind of a kind of the hierarchy of strength. So a strong opioid is going to be the strongest pain management drug, but you're not going to use that as your first line. That would be pretty dangerous. So you're going to want to start down here and work your way up as these, or if these ones aren't working. Okay, so you can tell I'm not a Richmond supporter. I don't hate you guys. Congrats yesterday. All right, so pain is transmitted via nociceptive neurons. You have A delta fibers for fast pain, C fibers for slow pain, and eicosanoids are substances that potentiate pain. So these are leukotrienes and prostaglandins. If you have these acting around, they're going to make pain worse. And these do this by opening up sodium channels, which then enhances the pain. So we need this enzyme called cyclooxygenase, or COX, for prostaglandin production. And so our non-steroidal anti-inflammatories are going to be COX-2 inhibitors, or you can think of them as COX blockers, or not Richmond in 2018. Haha. So there are going to be two types of this COX enzyme. Only COX-2 is pro-inflammatory. I haven't actually finished this. The reason why we don't use COX-2 selective inhibitors is to do with platelets, I'm pretty sure. I think it can lead to some issues there, but I'll have to double check that. So in general, COX-1 is going to be physiological. It's for platelet aggregation. Yeah, so I'm pretty sure it just leads to platelets aggregating more because you're going to have more of COX-1. Targeting it is going to be bad for the kidneys. Again, this is something you're going to cover in second year, but prostaglandins are pretty important for keeping open the afferent arteriole going into the nephron. And so getting rid of these prostaglandins is going to be pretty bad in that sense. And it's bad for the stomach because COX-1 is protective of the stomach lining. COX-2 is pathological, released by tissue damage, stuff like that. And yeah, bad for the kidneys, bad for the heart. And this is a little diagram that kind of shows this. So we're going to have COX-2 here. Feel free to look through that in your own time, or let me know if it's not clear. So to start off with our core NSAIDs, we have ibuprofen, which is a non-selective COX inhibitor, which also has antiplatelet effects. Can lead to sodium retention, GIT disturbance. And we use this for mild inflammation, fever. It's just Nurofen. Aspirin irreversibly inhibits COX-1 at low dose, and it's non-selective at high dose. And so at low dose, we use this as an anticoagulant, especially in acute vascular emergencies. Aspirin's often used. And then at a high dose, it becomes an anti-inflammatory. But it can be pretty dangerous, and we're going to cover that on the next slide, I think. Meloxicam is mostly selective for COX-2, but also there's a bit of COX-1 action. And diclofenac, that's just Voltaren, topical cream, also a COX inhibitor, just not as dispersed throughout the body. So with aspirin overdose, we can lead to salicylism. I think that's how you pronounce it. But if you have an acute aspirin overdose, it leads to all sorts of nasty stuff like tinnitus, deafness, gastric ulceration, gastrointestinal bleeding. I think it does this by impairing cellular respiration, I think. According to my notes here, it uncouples oxidative phosphorylation. So that's nasty. And it also, so it leads to respiratory alkalosis at first. And this is because salicylates stimulate the respiratory center in the medulla. And if you're going to be breathing too much, this is going to lead to respiratory alkalosis because you're going to be getting rid of too much carbon dioxide, I guess. I wouldn't worry too much about those details. So if you're alkalotic, you're going to want to correct these abnormalities. So first of all, you can give them activated charcoal, which is going to stop further absorption of salicylates, or you can give them forced alkaline diuresis to balance this out. And they might even have to be put on dialysis, since this can lead to renal failure. Paracetamol is not an NSAID. So it's centrally acting. They're not really sure how it works, but maybe COX-3 enzyme inhibition. But the metabolites of paracetamol are hepatotoxic, so it can lead to liver failure if you overdose. So the enzyme CYP450 in the liver metabolizes paracetamol to NAPQI. I don't know. Yeah. And then this is conjugated to be excreted by glutathione. But if you run out of that, then this can lead to hepatotoxicity. It's a toxic substrate. But you can give them N-acetylcysteine to treat an overdose. Yep. So yeah, in general, the side effects are less dangerous than other NSAIDs, like aspirin, but you really don't want to get liver failure, so you've got to be careful with it. And just use in fever, pain relief. So now from NSAIDs to SAIDs, so these are our steroids. So generally steroids are produced in the adrenal cortex, and these are produced from cholesterol precursors. And so the outer layers of the adrenal cortex, what's produced there can be divided into glucocorticoids and mineralocorticoids. The outer layer is going to be mineralocorticoids. So this is going to be aldosterone, again, something you'll learn a lot more about next year. This is for fluid and salt levels. The next layer down produces glucocorticoids. And this produces, so this is cortisol, and this has an anti-inflammatory activity at high concentration. And this is used to regulate sugar levels. So glucocorticoids work under a negative feedback loop. So the more glucocorticoids that you have in the system, the less that you're going to be producing. And mechanism of action is it inhibits phospholipase A2 and also NF-κB. If we go back a few slides, you can see that it works up here. So from membrane phospholipids going down to arachidonic acid, which is then the precursor that's acted on by COX-2 and COX-1. So we're just stopping this step here. All right. And this is used in adrenal insufficiency or inflammation and allergies. So our core glucocorticoids, we have prednisolone. So prednisolone can raise blood sugar levels in diabetics. And we have dexamethasone, which is the most potent. Fluticasone, used in asthma. But if we give too much of these glucocorticoids, this can lead to Cushing's syndrome, which has a number of nasty effects like growth suppression, osteoporosis, hypertension, increased risk of infection, central adiposity. And you can also get adrenal insufficiency post-withdrawal. And this is because of that negative feedback loop. So the body's going to stop producing cortisol because of the glucocorticoids that are being put in the body. And then when you stop administering it, I suppose there's a latency. So you're not going to have enough cortisol being produced at first. Cool. Just a diagram summarizing some other stuff you see in Cushing's. Opioids. So nerves have 3 opioid receptors, mu, delta, and kappa. These do all sorts of things, but for all intents and purposes, we're going to be focusing on the pain and analgesic effects. And opioid targets the mu receptor. It's good to really make sure you know that one. So these open the calcium channels on the first order neuron, which means, so this is the one before the synapse, which means it can't release the neurotransmitter. And then it opens the potassium channels on the second order neuron, which means it's hyperpolarized. So it can't then depolarize and fire off the signal. And this inhibits release of all sorts of stuff. This can lead to a bunch of nasty stuff like respiratory depression, because opioids lead to a centrally mediated decrease in respiratory rate, which isn't great. And these central effects are going to be what also leads to sedation and stuff. It's also going to have some gastrointestinal effects. And you're going to see loperamide later, which is an opioid that acts solely on the gastrointestinal tract. It's used for diarrhea. Yep. So core drugs, we have codeine, morphine. Codeine is basically just weak morphine, 10 to 20% the strength. Not used in breastfeeding women because it can lead to central nervous system depression. Fentanyl is a nasty one, very intense, only rarely used for severe pain, and can lead to pretty high dependency. That's the thing you have to watch out for with opioids. They can lead to dependency. But yeah, fentanyl's a really nasty one. Tramadol, very weak opioid agonist, which inhibits serotonin and noradrenaline reuptake, and leads to less dependence and respiratory depression than other opioids. Naloxone is a drug that's used for opioid overdose, so it's going to have the opposite effect. Can lead to hyperalgesia, so that's going to be more pain, I guess. Yeah. Loperamide, it's not able to cross the blood-brain barrier, so it's going to work in the gut, and used for diarrhea, but it can lead to constipation. And that's basically opioids are going to slow the contraction of your smooth muscle in the gastrointestinal tract. Pethidine, medium strength, preferable in childbirth because it's got a short half-life. Methadone, it's a strong opioid for people addicted to opioids. Again, probably don't need to know all of this. Dextromethorphan, used to stop coughs. Again, the further down the list we go, probably less important. It would be nice to be familiar with it at least. And then we just have a little diagram summarizing the strength of each. Yeah. All right, local anesthetics. So these block sodium channels by binding to receptors on the inside of the channel. So yeah, these are most effective on A delta fibers. And remember that anything downstream is also going to be blocked. So the order of loss, this is actually pretty important to know. Knowing that pain is going to be lost first, then temperature sensation, I'm pretty sure it's warmth and then cold, then touch and then pressure. And this is all to do with the myelination of the nerves that are being impacted by the anesthetic. So it's got to be more effective on those with a smaller diameter or less myelination. Yeah. So with esters, Richard probably taught you, I don't know if Richard would have given you this lecture, but he did for us. And he always told us that if it has no I in the name before cane, then it's going to be an ester. Esters are broken down in the liver, longer half-life. Amides do have an I in the name before cane at the end. And these are broken down in the plasma and have a shorter half-life. And both of these are going to be renally excreted. So bupivacaine, we can see there's an I here before cane, so this is going to be an amide, leads to respiratory depression, heart depression, vasodilation. Lignocaine, also an I here, so it's an amide. This is used for nerve blocks and epidurals. It's been a long time, but I think it's used in dentistry. Again, same side effects, can cause corneal damage. Tetracaine, there's no I here, so it's going to be an ester. Leads to respiratory depression, heart depression, vasodilation, central nervous system effects. And yeah, these are going to be, I think that's the other way around again. Again, I'm going to make a note to check on that note, but for now, check or use this and ignore this bottom bit. All right, I've ripped this straight out of last year's slides, so thank you, Jasmine, if you're watching this. These are some things that are going to impact the efficacy of local anesthetics. So lipid solubility and potency is going to affect it because of the because it has to go inside the cell. And then we have the order of loss here. Ionization status. So it has to be non-ionized across the membrane. So if there's inflammation, it's going to be a more acidic environment. And that's going to mean that it's going to be more ionized, which is going to mean that less can go into the cell because it has to be non-ionized. So it's better in a basic environment, which is kind of nasty because you might need it in an inflamed site and it won't work as well. Use dependence, it's only working in open and inactive states. My video might be blocking the thing on the right, but there's the thing where it's it can be a closed channel, an open channel, or an inactive channel after being opened. It's not going to work on channels that are in the closed state. So the more channels that are open or inactive, the greater the degree of the block. And then absorption, so this is reliant on the dosage, site of injection, blood flow, vasoconstrictor effects, which are going to prolong the effect and also reduce the systemic spread. Cool, so let's see how we're going for time. All right, might go a bit over an hour, but that's okay. What is the order of recovery for anesthetics? All right, yep, so it's going to be B. Motor, which wasn't in the list earlier, but motor is going to be the last one that's lost, I think, yeah. Deep pressure, light touch, warmth, cold, pain. And I think the giveaway here is probably the pain is going to be the last one to recover and the first one to go. Activation of mu receptors blocks which type of channel? Potassium, sodium chloride, or calcium? Yep, it's going to be calcium. Potassium is going to be activated on the second order neuron. Which of the following should ideally be blocked by NSAIDs? Yep, COX-2, not worrying about the platelet effect here. Ideally, we want to block COX-2, and it's really because of COX-1 still firing that we have some platelet effects there. But it's still our goal not to target COX-1 because, again, as you'll learn next year, that leads to all sorts of nasty stuff like peptic ulcers and so forth. Prolonged glucocorticoid excess leads to which of the following? And if someone could put in the name of the condition as well, that'd be great. All right, cool. Yeah, cool. So it's going to be easy bruising, thinning of bones, and susceptibility to infection. And this, as Alex said, this is Cushing syndrome. So yeah, this is something, I don't know. I always found it a bit weird learning about Cushing syndrome. It feels to me like it's largely about rote learning. But I've always personally found cortisol to be a pretty confusing drug anyway, not drug, substance. So, you know, I'd say go back to the diagram that I put in the earlier slide and just maybe make some flashcards so that you can really learn to recognize Cushing syndrome. And what is the mechanism of action for local anesthetics? Binds to intracellular part of sodium channels, phospholipase A2 inhibitor, COX-2 inhibitor. Yep, awesome. So it's going to bind to the intracellular part of sodium channels. Cool. Have you guys covered cardiac drugs? Would someone just be able to let me know in the chat, just so I know how much detail to go into here? Have you guys covered anything? Or like, have you started studying cardiology? Okay, cool. Well, all right, nice. Hopefully, I'll try to make it not overly jargonistic, and hopefully this can make some sense. There's going to be some bits that are really, really going to be weird, and cardiac pharmacology is a bit like that. But give it a shot. We had an ICL topic about it. Nice. Okay, cool. Well, yeah, that'll be a good launching pad for us to work off of. Nice. So the main cardiac issues that we're going to be wanting to addressing here are hypertension. So the way we're going to do this is reduce the blood volume and total body water, and also dilate the vessels around the body. Angina, so this is just going to be pain. It's caused by the heart muscles not getting enough oxygen. So we're going to want to increase cardiac output and blood flow to coronary arteries, and also decrease cardiac oxygen demand. It's a little bit of a weird one because some of the drugs for angina can be a little bit counterintuitive. I'm pretty sure like beta blockers and stuff are used for it. But I think in the end, the most important thing would be to make sure that it's not in a state where it needs more oxygen than it's getting. So yeah. Heart failure. So cardiac output is not enough for oxygen demand. Yeah, so we're going to want to increase the cardiac output, reduce total body fluid, which is going to mean that if there's more fluid past the left ventricle, then that's going to have more, it's going to have more stuff it's going to have to push past. So if we've got heart failure and the heart isn't pumping properly, we don't want all of this stuff here that's increasing the resistance that we have to push past. So that's another thing we're going to do. And also prevent tachycardia because, and you guys will learn about the Frank-Starling law in physiology, because this will give us more time to allow the ventricles to fill so that with every contraction, we're getting more blood around the body. Arrhythmias, so faulty conduction causes irregular heartbeats. Yep, this is the one that messes with me, and please don't feel bad if you don't get it the first time around. And please feel free to send me a message if you're confused. All right. So the ABCDs of cardiac drugs. So to start off with, we have our angiotensin converting enzyme inhibitors and angiotensin receptor blockers. Yeah, we'll go into that first. And this is the RAS system, which you guys will get pretty familiar with. I'll refer back to this in a sec. So we have ACE inhibitors. The best way to identify these is to find the drugs that end with pril. So perindopril, captopril, enalapril, ramipril. These are all ACE inhibitors. And these stop the conversion of angiotensin 1 to angiotensin 2 and also inhibit breakdown of bradykinin. But to start off with, the most important thing is knowing it stops this conversion. So looking at this, we have ACE, which is found on mostly in the lungs, that stops the conversion of angiotensin 1 to angiotensin 2. And as you can see, angiotensin 2 has all of these effects. It increases sympathetic activity, it increases sodium chloride reabsorption, potassium excretion, it increases aldosterone secretion, which you may remember is about salt and fluid retention. It leads to arteriolar vasoconstriction, and leads to ADH secretion, which is going to be about getting more water back from the renal tubules into the blood. So if we already have high blood pressure, for example, we're not going to want a lot of these effects. It's going to be increasing the amount of the volume of the blood, and also it's going to be constricting the blood vessels, which is just going to be putting even more pressure on the blood vessels. So that's not what we want. So if we use an ACE inhibitor, it leads to vasodilation and less sodium and water retention. So using hypertension, heart failure, remember the thing about wanting to push past less resistance, and also diabetes. You don't want to use it in potassium-sparing diuretics, mostly to do with the renal reabsorption stuff. It's going to lead to high potassium. also not in renal failure or pregnancy. And the side effects, there's a little mnemonic, which is catch with 2 H's. I think the buzzword for this one is a cough. So it's a dry cough that these people present with. And that's often a reason to put them on the next drug. If you guys want to just read through this later, that's cool. So a lot of the time, if someone's not doing well with an ACE inhibitor, or if they've got a cough that is really annoying them, they'll be put on an ARB instead, which is pretty similar. So these end with sartan. So it includes losartan, candesartan, valsartan, irbesartan. And these block angiotensin 2 from binding to the to an angiotensin 2 receptor. Again, similar effects, using similar things, and the key one is patients intolerant to ACE inhibitors. Contraindicated in potassium-sparing diuretics and renal failure, and it can lead to hypotassium, decreased glomerular filtration rate in the kidneys, low blood pressure, and it can also be teratogenic. Nice. And so here's a little diagram. So the original diagram only had stuff for ACE inhibitors, but ARBs work here. You can tell by the little crappy cross that was my work. Anyway, beta blockers. So as we talked about earlier, these are the ones that end with a lol. So atenolol, bisoprolol, that kind of stuff. Mechanism of action, they're going to be a beta-1 adrenal receptor blocker, cardioselective, as we covered earlier, especially atenolol and metoprolol. They're going to be more cardioselective. Used in all sorts of things like angina, hypertension, stuff like that. I guess with angina, it's going to mean that the heart's not going to be pumping as hard, so the cardiac muscles aren't going to need as much oxygen. Yeah, not used in asthmatics for the reason we covered earlier. It also has an effect on beta-2, diabetics, and those taking calcium channel blockers. And we'll cover why a little bit later. And it can lead to rebound angina, bronchoconstriction, exercise intolerance, stuff like that. Again, a lot of this is rote learning. You can kind of work it out if you really understand the mechanism of action, but yeah, pharmacology isn't a favorite of a lot of people because it can be a bit of rote learning. But it's really satisfying when you get it. And that's kind of why I like it. It's a bit of a grind along the way, but it can be really satisfying when you finally know you've got it. So calcium channel blockers can be divided into 2 types. Well, first of all, they block the L-type calcium channels. This last bit is a little bit incorrect. I'll tell you why. But in the end, this decreases the contractility. So more calcium means more contractility, which means stronger contraction. And also AV conduction. I'm not sure if you guys would have covered physiology or electrical pathways through the heart. But if not, you'll definitely be covering that pretty soon. So we have our non-dihydropyridines, for example, verapamil, and these act on the heart. So these are used for hypertension, angina, atrial fibrillation, atrial flutter, or just supraventricular arrhythmias. Supraventricular just means above the ventricles. So this could be the AV node, or it could be the atrium, or whatever, just something above the ventricles. And dihydropyridine drugs include amlodipine or nifedipine. So it's just the ones that end with dipine. And these act on the vascular smooth muscle. So non-dihydropyridine on the heart, dihydropyridine vascular. These lead to hypertension and angina, and these are going to have their own separate effects. But in general, the side effects are summarized by the mnemonic are benched. So reflex tachycardia, bradycardia, edema, nausea, constipation, headache, erythema, dizziness. All right, so diuretics. There's a lot of different types of diuretics, but we're only going to be covering 3. So we have our loop diuretics. which include furosemide, bumetanide, and torsemide. I'm so used to seeing it on paper, I don't even know how to pronounce it. But anyway, these act on the loop of Henle. Again, not sure if you guys have covered this, but it blocks sodium potassium chloride pumps, leads to less sodium retention. If you have got more sodium retention, the water is going to be staying in the body as well. And this leads to things like ototoxicity, so that's bad for the ears, low potassium, stuff like that. Again, it might be a better idea to just go through this again once you're more familiar with it. There's not really much I can explain here that would be too much more than going through it and learning those side effects. Thiazide diuretics, these inhibit sodium chloride reabsorption in the distal convoluted tubule, again, in the nephron of the kidney. Yeah, and the side effects can be remembered by hypogluck. So hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia, plus metabolic alkalosis and hyponatremia. Used for hypertension and heart failure. And potassium-sparing diuretics, because especially with loop diuretics, you're going to be losing a lot of potassium. So if someone's hypokalemic, you're going to want to keep some potassium. So we use things like spironolactone and amiloride, which are aldosterone receptor antagonists in the collecting duct. But you also have to be careful because this can then lead to them being hyperkalemic, which has its own set of problems. So we often use this in hyperaldosteronism. So you might remember that aldosterone is released by the adrenal glands. So if you've got an aldosterone secreting tumor or something, this might be an option. And this is just a little diagram to kind of summarize all of that. You can see the loop diuretics act here, thiazides here, potassium sparing diuretics here. So we then have our nitrates. So this leads to vasodilation, it does this through increasing cGMP, and this dilates your veins more than your arteries, which will then reduce ventricular wall tension by decreasing the preload and afterload. So those are the concepts you'll be covering in cardiology, but afterload is the one about how much is going out. Preload is about resistance going back in. You'll learn about that. Usually given as a transdermal patch, so across just a patch on the skin or under the tongue sublingually. It can be used for acute angina treatment or prophylaxis, maybe if someone's about to go and do exercise. They can lead to hypertension, and you want to watch out for it with Viagra. You'll probably learn about that. Side effects, it can lead to a headache, reflex tachycardia, stuff like that. And I think a key thing with nitrates, the thing that kind of makes it stand out is going to be you can develop nitrate tolerance. So you'll need a nitrate-free period every day. So it's about 8 hours per 24 hours. Wouldn't dilating veins increase flow back to the heart? So why? It's still going to, I think it's still going to have some impact on the arteries. That's a good question. I think it might have some effect. It might push more of the arterial blood into the veins, because I guess you're going to have to make up for that, that increased venous dilation. And that blood is going to then come through the, from the arteries. I'm just guessing that. But I think in general, understand them as distinct concepts. It dilates the veins more than the arteries, but in general, it affects both preload and afterload. Yeah. Okay, so antiarrhythmics. Everyone's favorite. So we have class 1. These are sodium channel blockers. And I hope you can see these diagrams over here on the right. You have class 1A, which include quinidine and propanamide. which are used for atrial and ventricular arrhythmias. And these increase the AP duration. So this is the one down the bottom. So if the AP duration, you can see it's really stretched out here. And that's going to mean that you're not going to be contracting the heart as often. Yep. And we have to watch out for torsade de pont, or how you pronounce that, I don't know French. That's basically another type of arrhythmia that you'll see as a result of using some cardiac drugs. So it's a really dangerous one. And it's a bit sad that, yeah, by trying to fix the by trying to fix the arrhythmia with an antiarrhythmic, it then puts you in another arrhythmia. But that's something to note there. Class 1B, that includes lidocaine and mexiletine. This is used for acute ventricular arrhythmias, so generally after or post-MI, and this decreases the action potential duration, as you can see here. It's a bit shorter. And class 1C, propafenone, for supraventricular tachycardias, like atrial fibrillation. So it's going to prolong the effective refractory period in the AV node, but it's going to have no effect on the Purkinje or ventricular tissue, contraindicated in post-ischemic heart disease. Okay, so class 1A, B, and C are all sodium channel blockers. We then have 3 more types of antiarrhythmics. So these include class 2, which are beta blockers. These decrease the gradient of sodium funny current, and this slows the rhythm of the heart. Yep, so this is used for supraventricular tachycardia, atrial fibrillation, stuff like that. Class 3, potassium channel blockers, increase AP duration, can also lead to torsade, leads to atrial fibrillation, atrial flutter, stuff like that. An example of this is amiodarone, which is used for supraventricular and ventricular arrhythmias. Side effects include photosensitivity. You're going to have some thyroid effects, also pulmonary fibrosis and prolonged QT interval. And you can also have some deposits in your eyes and halos in your visual field. I think this one's mostly pointed out just because of, I think it's a pretty common potassium channel blocker, and also just a lot of side effects. Class 4, this is a calcium channel blocker. This is going to target the plateau phase, so this bit right here. And this prevents supraventricular tachycardias. It's used for atrial fibrillation rate control, atrial flutter. Yeah, I'm sorry if this seems a bit like an information dump, because it can be a bit like that sometimes. And I genuinely, I wish there was an easier way to explain all of this. But I think it's going to be something where once you've covered more cardiology, it's going to start to make more sense. But even then, you're going to have to go back and really cover this a few times to drill it in. So we have adenosine, which is a pretty nasty drug. It hyperpolarizes the cardiac conducting tissue, which means more potassium, and slows the pacemaker activity via alpha-1 receptors in the AV node. It takes 15 seconds to work. It's given intravenously. It has a bunch of side effects: bronchospasm, flushing, hypertension, chest pain. It also gives you a sense of impending doom. So yeah, you wouldn't want to give this one too much. And it's given for re-entrant supraventricular tachycardia, and it's antagonized by caffeine and theophylline. Digoxin, this inhibits sodium potassium ATPase, which increases intracellular sodium and calcium. This suppresses conduction. Increases contractility. So used for atrial fibrillation, heart failure. Don't use it. Well, reduce the dose when given with amiodarone, verapamil, diazepam. Increased risk of toxicity. So it decreases potassium and increases calcium can lead to nausea, vomiting, drowsiness, confusion, visual disturbances, AV block, sinus bradycardia. Digoxin, it's not really, I couldn't say for certain, but I'd say in general it's not used as a first-line drug because it can be a nasty one as well. I feel like I'm saying that about every second drug today. But anyway, we then have our lipid-lowering drugs. So we have HMG-CoA reductase inhibitors, and these are also known as statins, which are, well, statins are the #1 most prescribed drug in the world, I think. So there you go. These inhibit conversion of HMG-CoA to mevalonate, which is a cholesterol precursor. So this is used for high cholesterol, since you're then going to be producing less cholesterol. This is can lead to hepatotoxicity or myopathy, and also you can't drink grapefruit juice. So that's a shame. Fibrates, these include fibrosol fibrate, yeah. This upregulates the enzyme lipoprotein lipase, which leads to more triglyceride clearance, and also induces HDL synthesis. Can lead to myopathy, cholesterol gallstones, and this is used for hypertriglyceridemia. So I guess the key difference here, HMG-CoA reductase inhibitors used for hypercholesterolemia, and fibrates are used for hypertriglyceridemia. Right. Of course, I chose the topic with the hardest pronunciations. Oh well. Ezetimibe. So this is going to prevent cholesterol absorption at the small intestine. And this works on both. So these two, cholesterol, triglycerides, ezetimibe works on both. And so we have this diagram here that kind of shows what's not on work. So we have statins up here working on HMG-CoA reductase, stopping HMG-CoA going to mevalonate, which goes to cholesterol. Fibrates, LPL upregulation, which converts all this to free fatty acids and stuff. And ezetimibe over here in the intestinal lumen is going to be inhibiting this cholesterol absorption into the enterocytes. Cool. So we have a bunch of do's and don'ts when it comes to cardiac drugs. And basically, the bottom line is don't give two drugs at the same time to have the same effect. So, for example, beta blockers and ACE inhibitors both inhibit renin. And going back to the RAS system that we talked about earlier, we don't want to double up on that because that's effectively going to double the side effects that we're getting from targeting that pathway. So we don't want to do that. Yeah, I'd recommend just going through this, like loop diuretics and thiazides. Remember, there was the third type of diuretic that was potassium sparing. These two don't spare potassium. So if you give them together, for example, if you really needed to double up on the amount of diuretic or something like that, that would lead to low potassium. So we don't want to do that. And this table here is a bit of a guideline on what you would want to give together and what we want to be avoiding. Sorry, how does beta blockers increase contractility again? Yeah, I was wondering that as well. I don't think they do. I'll have to get back to that one. Let's see. Yeah, again, ignore that one for now. Another note for me to make in changing the post slides. So in summary, for hypertension, first line is going to be ACE inhibitor, calcium channel blocker, and diuretic. And then late stage, you can give them a beta blocker, heart failure, all of that. Yeah, I don't have a lot to add to this. So maybe just go through this in your own time. So we have some questions. So the predominant adrenal receptor in cardiac tissue is which of these? So it's going to be beta 1. The key word here is going to be adrenoreceptor. So you're going to have muscarinic receptors, but they won't be adrenoreceptors. What is the mechanism of action of statins? Yep, so it will be C. And these are used for high cholesterol. Vasospastic angina is likely to be worsened by which of the following? This is a bit of a tricky one. It's going to be, yeah, okay. So beta adrenergic receptor blockers, because these can cause rebound angina. Yeah, so you got to watch out for that. And which of the following best describes the mechanism of action of digoxin? Yep, so it increases intracellular calcium. And which of the following might be used to treat hypertriglyceridemia? Yeah, nice. So it's got to be fibrates used for high triglycerides. All right, nice. Oh, I thought that was the last one. Okay, the following vasodilator drugs are likely to evoke a reflex tachycardia, except for what? This might be a bit tough because I didn't really go through side effects too much because we're running a bit short on time. But let's run on. Verapamil. So reflex tachycardia. From my understanding, it's caused by the so when your blood vessels notice that you've got high, or if you've got low blood pressure in your blood vessels or something, then this is going to then send a signal back to the heart to tell you to increase the heart rate because you're becoming hypotensive. Verapamil, so you might remember nifedipine and amlodipine both work on the blood vessels because these are dihydropyridines, whereas verapamil is non-dihydropyridine, so it acts on the heart. So it's not going to have that feedback telling you to increase your heart rate. And nitrates and prazosin are both going to work on blood vessels as well. A patient presents with acute paroxysmal supraventricular tachycardia, unresponsive to vagal maneuvers. Which drug would be indicated in this scenario? I'll just show the answer. So this is going to be adenosine because this hyperpolarizes cardiac conducting tissue and slows pacemaker activity. Again, this is probably a bit tough if you haven't gone through. Oh, some people got it, nice. But if you haven't gone through all of this in class, this is going to be really tough to get on your first day of learning all these drugs. So don't be hard on yourself. All right, that's all I've got. So thank you everyone for coming today. I hope you all learnt something from all of this, even if it was a little bit much at times, because I understand that pharmacology isn't everyone's favorite subject and it can be a lot of just rote learning stuff a lot of the time. But trust me, as I said before, like my number one thing for learning pharmacology was always make Enki cards. And you guys have access to the Denki deck, I think. So there might be some cards in there. Otherwise, if you want, if there's anything you're confused about, if there's anything else you need, just shoot me a message and I'll get back to you as soon as I can. Cool.